but there is a question of you have to deliver an effective response. And there's a bit of a meta-analysis here. So comprehensive geriatric assessment only works if you can actually influence and manage the change. Teams of liaison teams or geriatricians going around writing in the notes, giving advice to people which is ignored is no good. So there's a fundamental issue of the culture and teamwork of a hospital behind a lot of this sort of thinking. So I'm just saying a few words about a team. This is now, we developed this about 8 or 9 years ago, the liaison team for acute medicine. We have liaison teams also in surgery. We're just piloting an oncology liaison team. And essentially this is a model to deliver a comprehensive geriatric assessment and link that to a form of, a sort of appropriate form of case management for our system. And OPALs are now in existence in quite a lot of hospitals in the UK. But the principle is we have a team, it's a nurse or therapist doing a generic CGA-based assessment and a geriatrician doing the more specialist clinical assessment, reviewing proactively and systematically all admissions over 70. The reference is at the bottom there if you want to read the paper. And there's really two things to think about. One is for those difficult and complex patients who are the patients who are going to struggle in your standard acute medicine service, who they are and get them to an appropriate environment. Being on a noisy acute admission ward is not a great place to be if you have delirium. So one of the models for our hospital was identifying the right patients, not because they're ill, but because they have complex needs, and fast-tracking those patients to a specialist ward. But the other thing is identifying, if you like, those chronic syndromes, falls, continence, and so on, which may not be relevant for that acute admission, but equally it's important in terms of ongoing case management. And then the challenge then is what you do when you've identified the problem. How good is your fall secondary prevention system? What do you do about continence care? And again, that's a local issue. And this is just some data. It's very, very old, but just to say, at the time and place, many years ago at Guy's St Thomas's, this delivered a transformation or change. Length of stay went down, and all the sort of measures of did we identify stuff improved. This is another slide that you're not supposed to read but it just shows a good news story at the time. And just at that period, we were running the lowest length of stay in the UK for acute older medical admissions, with good quality indices as well. So it really did make a change. But the question is, you can introduce a CGA-based assessment team and achieve nothing at all. So the improvement approach is not the CGA as the principle. How you make that work is something you need to work through the principles of improvement in your local service. Now, if we then move on to delirium, delirium's an interesting one. I went to a hospital recently, visited a struggling hospital, and there was a patient in the corner of the ward with obvious delirium, agitated, the cot sides up, clearly in a lot of distress. And I asked the junior doctor there, saying, well, that patient's got delirium, haven't they? Show me your guideline as to how you approach management of delirium. And after sort of 5 minutes of hunting, they found the 44-page dementia guidance in their intranet. And, you know, you can't be serious. No guidance, no information. When I meet the starting doctors who in our hospital have graduated from everywhere in the UK, and I always ask them two questions. You know, who's heard of the Waterlow scale for those who haven't heard of it, for risk predicting pressure sores? About 10%. So we're not teaching our medical graduates anything about one of the major risks for older persons. Who knows how to manage delirium? Another 10%. And yet we have a syndrome that is really, really important. A third of acute medical admissions over 65 experience delirium during that stage. Hip fractures more. If you end up in ICU, even more. And with all the harm that goes with that. I mean, it's obviously very, very important. And yet why, as health providers, as health professionals, we're just not engaged in this agenda. So, and it's clearly, it extends length of stay, it increases long-term institutionalization, as well as hugely distressing. And we heard from the keynote from Nancy last night about her experience with her father, who was experiencing delirium. Now, this is then the quality challenge. This is actually an abridged version of what to do with delirium from our National Institute of Clinical Excellence. This is a really excellent evidence-based review. The evidence isn't great, admittedly, for what to do with delirium. And I think the point of this is to say, how on earth do you implement this? You can do almost everything. It's complex, multifaceted, and the conclusion, the recommendation from NICE is then create an individual care plan by a specialist team within 24 hours. Now, you do that for 30% of your hospital patients over 65, and you can see you'll be doing nothing but having specialist delirium teams. So it's back to that CGA question of how do you integrate these principles into effective care? And obviously, one of the principles of improvement is simplification. So just briefly, we had this problem, and we'd got a slightly better than 44 pages, 2 pages, but a delirium guideline that could be better. And as we do quite a lot, we say, we'll give the problem to some enthusiastic young junior doctors to go away with it. And on your seat, you have the delirium card, so that's your freebie, your party bag to take home with you. But this is just a stab at saying, how can we simplify to the bare essentials what can happen? And of course, they came up with a nice algorithm. And they've simplified it to something that has a possibility, with a bit of do's and don'ts in the back. Now, we have a guest appearance from Mark Kinines, who's a colleague geriatrician, who we didn't know he was going to come, but he's here, who's leading our delirium improvement work. So, Mark, if you just want to say a few words on how we're getting on with that now.
Well, thank you, Adrian. I mean, I think the key thing is both the recognition and the response to delirium. And in terms of recognition, we have developed a walk-around clinical team to try and case find. And at the same time as walking in the wards, encourage and promote through knowledge and awareness, such as this, and working with the ward sisters, the recognition of delirium, especially in the surgical wards. And then in terms of the response, the team is doing the same thing, as well as developing electronic referral mechanisms back to the specialist team. So through those 2 routes, we've making a step change, and we will be developing tracking systems around the rates of delirium management and response.
Thank you, Mark. And just an example of what you can do in improvement. I mean, these are our experts. These are trainee doctors, so in our terms, sort of about to be consultants or heading there in geriatric medicine. But I gave them the sort of similar slide and about 20 minutes chat on improvement science, and then said, go away and design something that might work. And this took an hour and a half, admittedly of an expert group from South London, and they came up with a bundle. And just to take one point, you probably saw on that long list, which you couldn't read, hypoxia. Well, their view, because they're expert and they know this, is you don't need that in your delirium bundle, because the one thing hospitals are good at, and early warning score chart ad, is doing the oxygen saturations. Get it out of the bundle, but actually constipation we're not very good at, hence they got it into 5Fs, hence the feces. But that's the sort of thing, and the next stage is, can we actually do some implementation work there? And that's where we're slightly struggling with in the UK, at least in delirium. But I'll move on to now end-of-life care. And I was at this meeting 3 years ago in Berlin, and we were looking at how do we quality improve end-of-life care. And we'd done some notes review, 20 cases, and some of them made me proud to work at our institution, and some of them made me ashamed to work at our institution, because it was just terrible standards of lack of awareness, assessment, poor decision-making that was just obvious from the notes, and other areas of outstanding issues. So we were in a training workshop, and we were learning about care bundles, so a group of us. So we said, right, we'll do an end-of-life care bundle, and hence the Amber Care Bundle was created, and again, we started with about 30 things we thought were important, but using the principles is to say we want to end up with 4 or 5 things that to some degree reflect the core of what the problem is. And the problem is in this area, complete lack of decision-making and very poor teamwork, poor communication both with the patients but with staff. And the group we were interested in identifying was patients who may be in the last couple of months of life. Patients who are clearly dying. We have quite a well-organized program in Britain linked to the Liverpool Care Pathway. But the amber group are those who fit in the middle. Maybe dying, but may not. And the question is, we need to be thinking of what can drive appropriate assessment for those. So this is the bundle. There's a website that's in the references at the back. We've also got a card for that, which I haven't brought copies for all of you. But in principle, it's Could you be an amber patient? That's the recognition phase. But in terms of what to do, there's two things to spot. One is that it's time limited, because this isn't just, well, we'd like you to think about this, but there's a clear plan. You might think, why do you need that? You might also think, why do you think the nurses need to be aware of the plan? Because it just didn't happen. So we're bundleizing teamwork here. We're actually using quality improvement to say, actually, you've got to have a plan and you've got to discuss it as a team. And the difference is, I was on a ward round a couple of weeks ago, and the nurse said, Dr. Hopper, I think that's an amber patient. And first of all, it was then a very easy and simple discussion to say, yep, agreed, let's run through what needs to be done, let's agree who's going to do what. And a discussion which in other contexts was just avoided. I know full well I don't have time, we'll come back to it, but just creating this bundle and an expectation to say, actually, you've got to think about these things, and there's only 4 of them, although behind that may be quite a lot of complexity. The other things is a clarity of appropriateness of escalation, resuscitation, and the most important thing is a discussion with patients and their carers on the appropriateness of on advanced care planning. So in particular, if patients are dying, should they be treated at home or in hospital? And the nurse on our program then said, well, that's fine, you've done the recognition, you've completed the bundle, but sort of, so what? Because the patient's, things still go on with the patient. And she woke up in the middle of the night and said, what you need is ACT, which is the monitoring phase as well. And I think that's, we found, really fundamental. So much assessment is what's the ongoing monitoring. So it is, and in particular, touch base with the patient and their carers. And we've now implemented that. It's pretty live in most of our hospitals. It's about 50 or 60 patients a day. Outcomes, difficult because it's control group, but a dramatically lower rate of readmission than in comparable group for the patients who are discharged. Hospital-wide, a very significant reduction in cardiac arrests. And the sort of headline figure is about 60 or 70% of patients who die are dying in their preferred place of care, which is the advanced care planning component of it. Now, that's all well and good, and it's sort of, and lots of feedback, of positive feedback from the staff. But the most remarkable thing about this is in England, we've actually managed to spread this. And remember, this was a non-existent blank sheet of paper 3 years ago at this meeting. So through the Department of Health Routes to Success program, which is an end-of-life care program, this is now one of the enabling methodologies, the so-called Amber Care Bundle. And we spread it initially to our twin hospital, King's College Hospital, then some hospitals in the Midlands in England. And we're now working with 30 hospitals in England to implement the Amber Care Bundle and are introducing a community pilot. So that story is just to say this is to some degree using very formal sort of quality improvement approaches to look at complex case management, teamwork, decision making. But that's really, really fundamental to these groups. Now, oh yes, I must say, and the British Geriatrics Society, Kevin gave a plug for it, and we've got an acute care group. We're looking at developing and spreading a similar thing, an acute care bundle in British Geriatrics. Very much the key things being delirium assessment and management. Now, that's from us, but I think we don't have the solutions, and one of the reasons we don't have the solutions is there are principles like comprehensive geriatric assessment, but the solution has to be local, and secondly, it has to be implemented with appropriate measurement and quality improvement. You can easily spend a lot of money and achieve nothing. So what we'd like to do, you had your thoughts for the few minutes there, talk to the same people, and you've heard from us to sort of say, these are a few principles we've applied. Say, take it a bit further and say, how might you do a little bit better with your service, maybe the models you've come onto? If you could do that for about 5 minutes, and then we'd like feedback from the floor. So we'd like you to tell us good ideas, and also if you have questions for us about the talk, we'll do that then. And of course, because it's a quality improvement meeting, there is the challenge to you, what are you going to do in your hospital next week, or next Tuesday, in fact? So 5 minutes, how are you going to take it forward? What are your good ideas? What do you want me to snap you with, Kevin? Sorry, excuse me. Sorry? Can you do that? I'll email that to you. Sorry? Is it? I've got one on memory stick, so... Okay, so I hope you've now solved all of older persons' care, but now is we're creating, Amber worked by creating a community, a network of interested people. So we're going to create a flash mob instant community. Mark is there with his roving mic, Kevin is there with his roving mic at the back, and over to you. And there's two things. There's obviously any questions for what we said, but the thing we're really interested in is what are your ideas, what are your issues, how are you solving the problem? So over to the audience, please.
Audience comments?
There's a question there, and have you got...
We'll start here, yeah?
One here, start here, and we've got you next.
Hi, I'm Beverly Atkins, and I'm from NHS Wales. I just wondered, you mentioned about the team, and I just wondered, how does social care interact in that?
Well, I mean, we can't cover everything. I think the seminar was called Acute Hospital Care for Older Persons, and we've narrowed it down to just... All we've tried to give you is throw up a few ideas and a few solutions. The key thing for the patients is that the acute hospital phase is very short, and the chronic care is really what's important. The admission avoidance is really what's important, and obviously, for those of us from the UK, the integration with social care is a real challenge. So, to some degree, we're looking at things like our integrated care work we're linking up with social services actually quite successfully in terms of smoothing discharge and getting rapid access to equipment. But we were knocked out yesterday. Torbay, 62 minutes to get equipment at home. One thought, that's success. Yep. Okay. So, right. Next question. Thank you.
Okay, and be short.
Thing work? Yes. Hi, my name is Ruth. I come from the Netherlands. I have been working with patients, elderly patients with delirium in hospital for a very long time. And one of our problems was that nurses saw delirium signs, for example, at night. And they called the doctor, and the doctor came next morning, 11 o'clock, during the round, and said, well, I don't see anything wrong with this patient. And the doctor is the one who, in the Netherlands, makes the diagnosis for delirium. So the nurses got very frustrated. It was really a problem. Then one of my colleagues, who is now a professor in the Netherlands, Professor Schuurmans, developed the Delirium Observation Screening Scale, which is a very easy scale. Nurses do not have to do anything, just to have to look at the patient during the daytime or evening time. And it's really a validated instrument to see early signs of delirium. And without a big implementation program, I dare to say that most hospitals in the Netherlands use the DOS as a good instrument to persuade the doctor to come and do the CAM and make a good and early diagnosis of delirium. So, a suggestion.
No, it's a great suggestion. The DOS, just for those, it's a sequential review, so the diagnosis emerges from that. But what a great insight into that's our cultural problem. That's why AMBER had so much traction in our hospital, because the culture between the medical staff and the nursing staff is all wrong. Mark, do you want to just comment on the delirium point there as our delirium expert?
Well, I think thank you for sharing the idea. We've emulated a similar idea and empowered the nurses to make a call and implemented and mandated an alerting system that triggers a response that is time limited and is driven across the whole organisation to get a more timely response. So similar success.
But she is right. There is a medical responsibility,
yes,
and there is a medical education responsibility.
Well, I think.
Go with the question.
Good, yeah, Tom.
I'm going to change topic.
What car are you going to talk about, Tom?
I'm not going to talk about Ford Mustang, and I enjoyed the slide, Kevin. Thank you. Tom Downs, for a geriatrician from Sheffield in the UK. Adrian, you asked the question, what are we going to do by next Tuesday? I'll share with you what I'm going to do by next Tuesday. I'm going to change my job plan, because on April the 1st this month, the 16 geriatricians in Sheffield all changed job plan. And so we now are seeing all patients referred to us in real time, because we want to achieve CGA within 2.5 hours of arrival, including full investigation. Our control chart measuring our bed occupancy has shown a signal change within the first 14 days. So by next Tuesday, my job plan's changed.
And to some degree, if we say the principle is delivering effective CGA in response to CGA, learning from Sheffield, Tom was an RHI fellow as well, and likes cars. So learning, that's one of the things, if we can just learn from good models, because they're out there. As I say, we introduced this structural model, the OPAL, many years ago, and it's time to refresh it. Was there a question down there?
I'm Peter Devlin. I'm a general practitioner in Brighton, and I'm also a primary care advisor to our acute local hospital. A question really related to, you've talked about the community pilot work. I'm very interested in that. And I wonder whether you share the view that I've increasingly coming to about primary care in its current model in the UK no longer being fit for purpose around meeting the needs of this group of patients.
I do think, but I would I agree with you about the general practice point. We're doing some integrated care work, and the sort of thinking, how do you respond to delirium in the community? The one thing that we know is bad for delirium is putting patients in an ambulance and sending them to hospital. And how do you but you need effective medical support. So I do think we've got to rethink our hospitals and also our community response. In terms of the community amber, yeah, there's actually, the pilot work it's very simple. Most of it translates with the obvious thing like decision making within 12 hours, but the principle of advanced care planning and the cardiopulmonary resuscitation issues are a little bit different, but it translates quite well.
But can I add a comment? We heard recently elsewhere of an excellent model developed by primary care in Ipswich, in which the team, led by a GP, who worked with the multidisciplinary team that went out to the community to respond to delirium call and stopped the patient coming in. So in a sense, much more patient-centred, with some outcomes that were a significant improvement in quality and admission.
Kevin, do you want to comment? Because it's a really important principle of, is there a design problem with our system?
Yes, so I think my question, which you've sort of answered, is with comprehensive geriatric assessment, does the physician involved have to be a geriatrician? Because, guys like us stay in employment because we're geriatricians, but in many systems there isn't the availability of geriatricians. But I guess, Annie, that's not the case. Mark, it doesn't have to be a geriatrician. It can be a primary care doctor. It can be hospitalist, internal medicine doctor.
I think the key thing is you need a knowledge base, a skill set, and I think all of us need to do some simplification work, because that's the thing. But there's not enough geriatricians, unless we, a bit like the Nigel Edwards talk, unless we train everyone to be geriatricians, there's not enough geriatricians to go around. So we've got to embed this in a slightly new system. Now,
next questions
come. Next question's here. There's a hand here at the front, Kevin, if you want to mic. There's a question there, I can't see. Yep, talk away.
Thank you. Isn't it embarrassing and shameful that we are discussing improving the care of the elderly in 2012? It's embarrassing, and I think we need to do more and more towards it, and I think you've shown some great examples there. Can I just ask you, I'm a cardiologist in United Kingdom, and I get lots of referrals from care of the elderly physicians. And I go to that ward with 28 very frail, comorbid patients, and I see 2 nurses looking after those 28 patients. How on earth will you be able to ensure that those 2 nurses will provide the best care to our patients who deserve the most intense care? What are we doing about, the Royal College is doing about ensuring, and you talked about that you're going to be accrediting wards, and I think that's where care can be improved by the Royal College accrediting wards, that if you are a care of the elderly ward or any other ward, you need to have the basic critical mass of staff working on that ward to improve the care.
So I think you're absolutely right, sir. My boss, who's the clinical vice president of the Royal College of Physicians, is at the back. Mark, if you bring Linda the microphone, I'm sure she'll be much more articulate about than I am. But so what we are trying to do here is make sure that this issue and this patient group gets on the agenda. And what we're trying to do at the Royal College and in the Department of Health and other at this level is to make sure that we call out exactly what you've said, and then we twin that with work that people like Adrian and Mark and lots of you good people and lots of other good people are doing. So the examples are there. Linda, do you want to add something to that?
I think I was just going to agree with that I absolutely agree that it's a scandal that we are having to talk about improving very basic care for older people. It breaks my heart. I've been involved in the healthcare system for 37 years, and some of this is still going on. So I very much believe that it's a matter of clinical and professional leadership, of saying we can do better.
Yep,
and we've got some examples here of how to do better. But I think, first of all, we've got to all wake up to the fact that the system needs to do better to care for our frail older people. What we're doing at the college is working in a very multifaceted way with different professions. I mean, I'm linking with the nursing profession, with other professionals, with the improvement network, to say that we actually need to bring all these facets together, including maybe redesign of our systems, talking more about generalists as opposed to super specialists, etc., that to say that now is the time that we are going to do better and we are going to treat our people with dignity, compassion, care, and as best outcome for them as possible.
Yes.
And certainly there's a sort of point, take specifically delirium. Almost certainly effective delirium care, including having an out-of-hospital mode, is cheaper care. So, getting it right. Having an undernursed ward does no one any good in the end, because you just get complications, pressure sores and falls, as well as extended length of stay. Now, we've only got 2 or 3 more minutes. Now, there's a question.
I got the mic.
Lily here,
Yes.
from the Netherlands.
Yes, it's me again. I'm sorry. I actually have a statement. I don't think you should do a comprehensive geriatric assessment when those frail patients come to the hospital, because they are not frail by then. They have been frail before. Yeah. And I think those assessments should be done in primary care. And the patient should bring a report of himself, of his situation and all the risks and the prevention points, and give that to you who treats him in the hospital. I'm
going to link you with Tom after the meeting, because you're absolutely right. What should happen, but what does happen is people turn up and we have to deal with the situation. We're actually running over time, so we've got one more question from lady at the back. Thank you for your patience.
I'll try to be quick. My name is Caroline van der Linde, also from Holland. Geriatrician.
You see, they speak strongly, the Dutch.
We take our opportunity.
You sure do.
I was hoping for an advice, because the struggle in my hospital is the falls prevention program. So suppose we succeed in screening for risk, but what do we do afterwards? Does anybody has advice to?
So can I tell you, if you read we at the Royal College, we've done a care bundle approach to a quality improvement program to reduce inpatient falls, and it's called Fall Safe, and the poster is outside. And if you email me afterwards, I will put you in touch with the guy who's led it. So we've, there are several different approaches to reducing inpatient falls, but this is one of them. We have run out of time. Thank you for your contribution and your energy. I would say I think there's been a great discussion. Gentleman over there said it's a scandal that we should be discussing this in 2012, and I think it is. I also actually personally think it's a scandal that in a meeting of 3 days long, talking about improving quality in healthcare, that we have 1 hour to talk about this really important patient group. And I'd be very grateful that when you're feeding back on the meeting, you feed that back. Because I think meetings like this should be full of this sort of stuff to give people like us time to exchange value. So please give feedback on the session. If you haven't liked the session or it didn't meet your expectations, then please give the feedback and please email us and tell us what was missing. If you have liked the session, please give feedback as well. And if you want to see more of this stuff on the agenda for this meeting, then please mention that in your feedback. Thank you for your attention.
Just a few minutes. Thank you, Kevin. And just that thing on falls prevention, we've got a quite good falls prevention. I think the Stratify assessment scale is used in Holland, or so I discovered, and that, you may or may not know, stands for the St. Thomas's Risk Assessment in Falling Elderly, because we developed that 15 years ago. So thank you. It's gone international. But I think, first of all, a great discussion. It's such a challenging problem, and I think if we had time to capitalize on the intelligence in this room, great models occurred, we could be much the wiser, but no time. Now, Kevin, you were going to explain how LinkedIn works, but LinkedIn, or email either of us if we'll send you the slide set there, and then included in that is some references, just the sort of websites, specific stuff for the Amber Care bundle. We have an app, the Guy's Thomas's Patient Safety app, that summarizes a lot of this stuff, and including the Route to Success Department of Health program that's sponsoring Amber. So thank you very much.